All right, we are going to talk about the lungs in this video. So we'll cover a lot of this gross anatomy of the lungs in lab next week, but really quickly, we've got two lungs, the right and left lung. The right lung is split up into three lobes, the superior, middle, and inferior lobes, and then the left lung only has two, just the superior and inferior lobes. And these lobes are divided from each other by fissures. So we have the right horizontal fissure and right oblique fissure. And then on the left side, we just have the left oblique fissure going up the side. Um, and this is where all of the bronchioles are going to travel into. So you can see our trachea here, primary bronchus, and then we've got the secondary bronchus, and then the tertiary or lobar bronchus or segmental bronchus down here. Right? The heart would sit right about here in that cardiac notch, and that's part of the reason why the left lung has only two lobes to it instead of that third as well. It needs a little bit more space. And so surrounding the lungs is the pleural cavity and pleural tissue. So we have the parietal and visceral pleura of the lungs. So here is one of the lungs. It's going to be deeper down beneath the ribs and intercostal muscles and the entire thoracic cage. They sit right above that diaphragm again. And if we look a little bit more closely at this area right here, where we would be looking at that kind of cross section of this tissue that's going to surround the outside of that, which is the pleural sac. So pleura means lungs. So if we zoom in on that, much like other pleural, or not pleural, but sacs, the protective sacs, there's going to be the parietal and visceral layer of those sacs. So the visceral layer is going to sit right on the surface of the actual organ itself. So on this case, that's going to be the lungs. And then the parietal pleura is going to sit more superficial to that. And so it's going to sit just under that layer of intercostal muscle and the ribs and stuff like that. And then in between them is the pleural cavity, which is going to have a bunch of serous fluid in it for a little bit extra cushioning. This is going to help keep the lungs protected, separated from other structures, provide that cushioning and stuff like that. So this is a really good structure to have around in the lungs. So not a lot of other things to talk about with the lungs, because we have talked a lot about, different structures already that are associated with the lungs, like the bronchioles, and the issues that can come up with the bronchioles. We've talked about the blood supply, so pulmonary circulation and stuff like that already. So we're not going to go into a lot of detail about that here in this video. We do also have nervous system control over the muscles of the bronchioles, and deeper down into the lungs and stuff like that. And so that's where we can get some of the bronchoconstriction and dilation, so expansion or contraction of those bronchioles. But looking at one additional disorder of the respiratory system, specifically in this case, pneumothorax. So again, plural refers to lungs, pleura. Pneumo also is going to be lung related. So pneumonia is an infection in the lungs. Pneumothorax is the medical term for a collapsed lung. So a rupture of the lung caused by trauma or disease is going to introduce air into the pleural cavity here, so the area surrounding the lungs, and that air pressure is going to increase on the surface of the lungs, and cause the actual lung to kind of collapse down, which because it breaks that surface tension of the visceral pleura to the parietal pleura. And so the visceral pleural layer is still going to be here on the surface of the organ, but the parietal stays out here underneath the bone and muscle area. And so basically, that pleural cavity is separating further from the two layers than it should be. And that surface tension, once it's broken, the lung is going to collapse due to just recoil, because that tension is keeping everything together under normal circumstances. And so once we break that surface tension, then the lung is going to collapse because these are basically just sacs of cells, those alveoli. And so there's not a lot of other structures in here to kind of keep them together and allow them to support themselves. So this is treatable. In most cases. It can include what's called manual aspiration of the air. So they will actually stick a needle in to that pleural cavity and pull the air out. And then any underlying causes of that pneumothorax are obviously going to be really important to prevent it from reoccurring or worsening once that air has been removed. All right, we are going to continue in this video and get into the processes of the respiratory system. So, there are a lot of different processes that happen within the respiratory system. We have pulmonary ventilation, external respiration, transport of gases, internal respiration, and then cellular respiration. So, pulmonary ventilation is the actual act of breathing, moving air in and out of the lungs. And so, this is what you're doing constantly all day long is pulmonary ventilation. And so, we're just moving that air. This is the expansion of the rib cage and then contraction of it and stuff like that. The diaphragm is contracting and relaxing during this. And this is going to then lead to external respiration. This is the exchange of gases between the air in the alveoli and the actual bloodstream. So this is that gas exchange happening deep down in the alveoli with all those pulmonary capillaries. And then we have the transportation of gases, oxygen and carbon dioxide, between the lungs and the body in the bloodstream. And then internal respiration is the exchange of gases between the bloodstream and the tissues of the body. So this is happening systemically outside of the lungs. And then cellular respiration is the actual cells within those tissues that are converting glucose and oxygen into cellular energy in the form of ATP. And this is going to produce the carbon dioxide as a waste product, which is then going to need to return and be expelled from the lungs. So inspiration is breathing in, expiration is exhaling or breathing out. And so for inspiration, the thoracic cavity is going to expand. It's going to get bigger. The external intercostal muscles are going to contract to help pull the ribs up and out. And the diaphragm is going to contract and flatten out a lot to increase that thoracic cavity. And then expiration is going to be a reduction in the thoracic cavity size due to the external intercostal muscles relaxing and the internal intercostal muscles contracting, pulling everything back down together. And the diaphragm is going to relax and go back to that very curved structure. So, one disorder that can happen here with this process is chronic obstructive pulmonary disorder, or COPD. So this can also sometimes be called chronic bronchitis or emphysema, although it's more accurate now to consider both chronic bronchitis and emphysema to be different components of the overall COPD. So in normal lungs, we are going to have the trachea down into the bronchi, down into bronchioles, and then into the alveoli. Well, with COPD, The bronchioles start losing their shape and getting clogged with mucus, and then the walls of the alveoli slowly get destroyed, which is going to form fewer larger alveoli, which is still not going to be enough surface area for the amount of gas exchange that is ideal for us. So they are larger alveoli, but the gases that are going to be down here more in the central part of that alveolar sac now, they are not going to get exchanged with the bloodstream the way the gases that are in contact with those cells are, because there's just not enough time to do that gas exchange. So we're losing that really, really important surface area there. So the chronic bronchitis part of COPD is what's affecting the bronchioles. So they are losing their shape. So they're going to start collapsing, narrowing the passageway. And then that mucus is going to further block airflow through the bronchioles. And then emphysema is the part that affects the alveoli specifically. So those are losing their elasticity and getting destroyed. And the alveolar macrophages are going to be working overtime, cleaning up damaged cells and stuff like that, as well as any debris that make it down there. And so that's all going to slowly destroy that. We're also going to get a lot of fibrous tissue developing, so scar tissue, which is going to further reduce elasticity in the alveoli. So this is going to cause some symptoms similar to asthma. We're going to have a lot of shortness of breath, specifically with expiration, so breathing out. And that's going to affect how efficient our ventilation process is. And then when you combine that with the alveolar damage and that reduced surface area, then we are going to have greatly reduced oxygen levels in the blood, which is going to lead to a lot of overall tiredness and weakness, excessive fatigue and stuff like that. So very, very similar symptoms to anemias, which affect the blood cells specifically. But it's still going to result in low oxygen levels outside of the lungs, out in the rest of the body, which is going to cause a lot of symptoms. So, there are some treatments for this. The same treatments that get used for asthma are commonly used for COPD as well. So the long-acting treatments like Advair, Dulera, Symbicort, stuff like that, as well as the rescue inhalers for albuterol. But people can also be given supplemental oxygen if they have a severe enough case, but the worse this gets, the less that can be done about COPD because there is no way to restore the damage to the alveoli, and there's no way to restore the damage to the bronchioles either. So smoking is one of the leading causes of COPD to develop. So if you do smoke, I would encourage you to at least try to cut back on it. It's not always realistic, I think, to expect people to just go cold turkey. That works great for some people. I don't think that's the vast majority of people. So reducing how much and how often you're smoking, or cutting it out altogether ideally, is one of the best ways of reducing your chances of developing COPD. But start with just decreasing how much you're smoking. And that goes for a lot of things. That goes for COPD, so overall respiratory health, cardiovascular health, mental health. That applies to everything. But do it in baby steps. Don't try to rush through it unless you feel like you are capable of doing that. But reducing or cutting out smoking is going to help reduce the chances of developing COPD, or if you have already developed it, then reducing or stopping smoking can help slow down the progression of it from there on out. All right, that wraps up those next two sections. We will finish up this series in the next video, talking briefly about development of the respiratory system in the next video.